Welcome, everyone, on this beautiful morning to the University of Washington Division of Cardiology Grand Rounds. My name is Jim Kirkpatrick. I am the Section Chief of Cardiac Imaging, and I am very happy to welcome you all to this pre-Thanksgiving version of our Grand Rounds. It is our honor to welcome one of our own this morning, Dr. Tiffany Chen. Dr. Chen graduated from the Massachusetts Institute of Technology with degrees in electrical engineering and biology. She completed medical school at Penn State, go Nittany Lions, currently fourth in the nation in football, and internship and residency at Brown University, currently seventh in the Ivy League, but did beat Harvard and Cornell this year. Dr. Chen was the first ever cardiac imaging fellow at the University of Pennsylvania following her fellowship in cardiovascular disease here at the University of Washington. And after her stint in the imaging fellowship at Penn, she was assistant professor at the University of Pittsburgh, and then back to the University of Pennsylvania, where she won the faculty award for outstanding teaching in cardiac imaging twice. Dr. Chen has been selected to numerous important positions in professional societies, including the Image Guide Echo Registry Committee, the Intracardiac Echo Task Force, and the Governance and Compliance Committee of the American Society of Echocardiography. She was also selected to the highly prestigious ASE Leadership Academy. Now, beyond the ASE, she has taken on leadership roles in the Society of Cardiovascular Computed Tomography, on the Education Committee, the Corporate Relations Committee, and the Annual Scientific Program Committee, and serves as co-course director of the Advanced Cardiovascular CT for TAVR virtual workshop. She won first prize in the 2022 ASE Hackathon competition, so you do not want to get on her bad side, or you may find your laptop in disarray. She is also the co-author on the ASE Prosthetic Valve Guidelines and is a member of the ACC Advanced Training Statement on Cardiovascular Imaging Writing Committee. She's participated in outreach work in underserved schools in Seattle and Pittsburgh, and served as faculty at an MRI course in India and an echo course in Da Nang, Vietnam. She has 27 peer-reviewed publications, 6 book chapters, and 34 national and international talks. And this year, she was appointed to the most highly prestigious appointment ever, and that is motherhood of the fantastically cute Luke, who I believe we will see at the end of this presentation. For all of these reasons and more, we were ecstatic to hire Dr. Chen away from Penn to join the University of Washington section of cardiac imaging, and for her to take on the leadership role of the Cardiac CT MRI Case Conference, and also significantly improve our education in transesophageal echocardiography. But Dr. Chen is more than all that. She was my clinic fellow several eons ago during her UW Cardiology Fellowship, and back then I asked our nurse Colleen about Dr. Chen, and her words still perfectly encapsulate this amazing individual. And I quote, "She is a funny unicorn mix in that she is compassionate and yet cranks through the work." Anyone who's read with her in the Echo Lab knows that that's true. She is really special, and she is also a genuinely fun person. And I will add that she is also an incredible speaker, and so I am truly honored to welcome to the podium the genuinely fun Dr. Tiffany Chen.
All right, well, thank you, Jim, for that very, very kind introduction. So it's a pleasure to be here to talk about one of my favorite topics today, which is multimodality imaging of prosthetic valves. I'll go through the why, the when, and how we approach prosthetic valves with imaging. These are my disclosures. I have nothing relevant to the presentation today. So the objectives today are to go through and help you understand how we use multimodality imaging for assessing prosthetic valve function. We'll describe the strengths and pitfalls of each of the imaging modalities, including echocardiography, CT, MRI, and some nuclear imaging as well. And hopefully by the end of the presentation, you'll be able to recognize the role of imaging in the management of all your patients with prosthetic heart valves. So as Jim mentioned, I was fortunate to be part of the writing committee for the recently released 2024 ASE prosthetic valve guidelines. So this guideline document was an update from the really old 2009 guidelines, and really incorporated multimodality imaging, as well as included, how we approach transcatheter valves, which is an update from the previous iteration. So what is the role of imaging? There's several important aspects of it. First is that imaging allows us to identify prosthetic valve size and type, and that has implications in terms of how we assess prosthetic valve function. In the presence of dysfunction, imaging helps us elucidate what the exact mechanism is, and we could break that down into two broad types. We can have abnormal hemodynamics with elevated transvalvular gradients, or have regurgitation that can be whether it's within the valve or around it in a paravalvular leak. We can grade the severity of dysfunction based on imaging and incorporate it into the clinical context, and determine if the patient is suitable anatomically for potential transcatheter intervention, such as valve-in-valve TAVR or TMVR, or PVL closure. So why do we need multimodality imaging? Well, as much as I like imaging, it's imperfect. There's no single modality that can 100% reliably characterize prosthetic valves. So we need to incorporate parameters from echocardiography that includes transthoracic and transesophageal echo. Cardiac CT has an increasing role in the assessment of prosthetic valves, as well as nuclear medicine techniques like FDG PET. And there is a small limited role of cardiac MRI, which I'll review. So what do prosthetic valves look like on advanced imaging? So these are some various types of bioprosthetic aortic valves. On cardiac MRI, you can see that a stentless valve has, you can see the leaflets a little bit more readily than in a stented prosthesis. This is a Medtronic core valve or Evolut valve, where there's just too much artifact from the metal to really be able to understand the structure of the prosthetic valve on MR imaging. However, CT has a very important role in identifying valves, particularly in patients who may not have the surgical op report. We can tell what valve it is based on its fluoroscopic landmarks, and this is similar to those who spend some time in the cath lab and how you can look at valves on fluoroscopy. Similarly, these are some examples of the fluoroscopic appearance of various bioprosthetic mitral valves and annuloplasty rings. Now, in terms of normal hemodynamics, this is largely dependent on the type and size of the prosthetic valve. And if you go through the ASE document, there are tables at the end that describe what are sort of the expected gradients and effective orifice areas of various valve sizes and types. Let's talk a little bit about prosthetic valve function. Prosthetic valve dysfunction can be characterized as either non-structural, that is due to prosthesis patient mismatch and other factors, or structural valve degeneration. And then there's also a third entity of thrombosis or endocarditis. This can lead to hemodynamic valve deterioration, which we can grade in several stages, and that can ultimately lead to bioprosthetic valve failure, which is irreversible and may be associated with significant clinical outcomes. One document that also describes this is when we look at aortic valves. There's the VARC-3 document that characterizes the types of bioprosthetic valve dysfunction. As mentioned, we can have structural valve deterioration. This is due to just generalized wear and tear of the valve versus non-structural valve dysfunction, which is generally patient prosthesis mismatch, which we'll define, or paravalvular leak, or you can have thrombosis or endocarditis. These lead to hemodynamic changes. And for the aortic, these are the definitions that they propose for stage 1, 2, and 3, based on the increase in the mean gradient of greater than 10 would qualify for stage 2. Increasing the gradient more than 20 would be stage 3, with a concomitant decrease in the effective orifice area and or decrease in the Doppler velocity index. So these are largely based on echo parameters that can then lead to clinical consequences in bioprosthetic valve failure. I'm not going to go through this, but a similar framework has been proposed for mitral valve dysfunction and mitral bioprostheses. What is prosthesis patient mismatch, and how do we define it? Well, it is as it says. It's a mismatch between the size of the prosthesis and the size of the patient, and this can be expressed in terms of the ratio of the effective orifice area to the patient body surface area. We do have to recognize that obese patients may have a lower ratio to meet that definition, and thus a higher threshold for qualifying for PPM. The definitions vary a little bit depending on who you talk to, but these are sort of the generalized definitions. It's highly prevalent, particularly in aortic valves, bioprosthetic aortic valves, surgical valves more than TAVR valves, and the balloon expandable TAVR valve more so than the self-expanding valve. It's associated with worse outcomes in terms of functional class. And there are subsets of patients, such as those with significant LV hypertrophy, younger patients, low flow, low gradient aortic stenosis that are at higher risk of developing PPM. And PPM, severe PPM is associated with increased mortality, as well as faster valve degeneration. So it's important to recognize and identify. These are a couple figures showing just the algorithm of how do you approach patients with elevated gradients and determine whether or not they have PPM and whether to follow them serially or to do further imaging such as CT to look for halt or intervention. The right-hand figure here shows the role for imaging in not only identifying PPM, but predicting the potential for developing PPM in patients undergoing potential valve replacement, where you incorporate the expected EOA with the size of the patient, and that might help you determine whether or not certain procedures need to be done, such as root enlargement or consideration for a TAVR valve rather than the SAVR valve. Now, how do we distinguish PPM from true stenosis or actual obstructive gradients? The ASC has this document has this figure that tells that suggests a stepwise fashion of how to approach this. In general, we look at the gradients across the valve, and as well as the Doppler contour, where if you have an early peaking contour, that's more suggestive of normal valve function and perhaps prosthesis patient mismatch rather than a late peaking contour that would suggest true stenosis. We can also incorporate not only echo but CT to look at the structure of the prosthesis in order to see if there are abnormal masses on it that could be causing obstruction, or if there is normal motion and function of the leaflets. So to delve into that a little bit more, CT has an increasing role in identifying masses on prosthetic valves, such as calcification from degenerative causes or thrombosis or pannus formation. The attenuation on CT can help us distinguish somewhat between pannus, which has a high attenuation number, versus thrombus or vegetation, which generally is associated with Hounsfield units that are much lower, less than 90 or so. Here are some examples that you can see here. This is a valve-in-valve, the tricuspid position that's associated with significant thrombosis of the valve. Pannus formation, the location also matters. This is pannus that is seen on sewing ring versus thrombus and vegetation, which tend to affect the leaflets themselves. Now, I showed you some bioprosthetic valves, and we talked about bioprosthetic valves, but there is also a role for CT imaging in mechanical valves, in the sense that we can see what the opening angle of the valve is, as well as look at surrounding anatomy, if there is, say, a root abscess or areas of dehiscence or a pseudoaneurysm that could be identified more readily on CT, perhaps than by TEE. And we can couple that with PET imaging for looking for signs of endocarditis. So this was actually a patient that was recently at Montlake, a young patient who had a mechanical AVR that was thrombosed, and you can see the arrow pointing at a very small thrombus that you could actually see on CT. And of course, you can appreciate that this leaflet is fixed and immobile. Normal opening angle is about 20 to 30 degrees. Certainly, this is much more than that. So speaking of thrombosis, there is an entity that's worth discussing, which is HALT, or hypoattenuation leaflet thickening, which can be associated with hypoattenuation affecting motion, or HAM. And this affects a fair number of patients who undergo TAVR, can be identified at 1 month in about 15% of TAVRs. The association with clinical outcomes such as mortality or MACE is a little bit unclear and up for debate, but there was a study recently published that showed that HALT is associated with greater incidence of subsequent structural valve degeneration, so occurring earlier. How do we define HALT? Well, it's hypoattenuation on CT and leaflet thickening, and we can grade it depending on the percent of the leaflet from base to tip that is involved in a semi-quantitative fashion. Here's an example of a sapien valve with significant HALT, which we can see in the diastolic phase affecting all 3 leaflets. And here's an evolute valve also with what we would call severe HALT. But the HALT without HAM is of unclear clinical significance. Usually we are looking for both. So here's some more examples. So here, this is a patient at 4 months after TAVR who underwent a 23 millimeter sapien 3. And was found to have elevated gradients, a mean gradient of 28, peak velocity of 3.6 on echo. This led to a CT showing HALT involving all 3 cusps and essentially the entire extent of the leaflet. And so this is severe HALT. And with during systole, there was restriction of the leaflet opening. So this patient was treated with rural anticoagulation, and at follow-up, gradients were much lower on transthoracic echo. Repeat CT showed resolution of the HALT. So moving on and talking about prosthetic valve regurgitation, we can have both intravalvular or paravalvular leak, important by imaging to identify where the regurgitant jet is coming from, the size of it, the tract, and the shape of it, because that has implications in terms of the subsequent therapy. And we could look at the mechanism or etiology of leak. So for instance, on CT, and we can see this on TEE as well, here's a patient with a aortic prosthesis and a flail leaflet. Dehiscence would appear like this on 3D echo with an unstable valve that has a lot of mobility there, and can be associated with paravalvular leak. This is a different example of a mechanical prosthesis in the mitral position associated with this large regurgitant jet here at the 7 or 8 o'clock position. So we've talked a lot about echo and CT. What about cardiac MRI? Well, here's where cardiac MRI may have a role, is in identifying and assessing prosthetic valve regurgitation. The power of MRI is in its ability to use the volumetric method to assess regurgitant valvular lesions. We don't have as great a capacity for assessing prosthetic valve stenosis due to resolution, temporal resolution, and other issues that make Doppler echocardiography still the mainstay for that. But there may be a role for quantifying the regurgitant fraction, regurgitant volume of particularly prosthetic aortic regurgitation. It is also the gold standard for quantifying volumes in terms of left ventricular size and left ventricular ejection fraction. When we talk about mitral regurgitation and the quantification of it by cardiac MRI, that's more through an indirect method of subtracting the phase contrast through plane flows through the aortic valve from the total LV stroke volume, from planimetry of the ventricular volumes. And so that could be more prone to error. Now, the other aspect of cardiac MRI is its power in assessing myocardial characterization and looking for remodeling as well as reverse remodeling. Aortic stenosis, progressive aortic stenosis, as we know, can affect the LV myocardium in terms of developing cellular hypertrophy that could lead to diffuse fibrosis and ultimately irreversible replacement fibrosis. These can be identified through techniques on CMRs such as LGE imaging or T1 and ECV mapping or extracellular volume mapping. Here's an example of a patient with severe aortic stenosis who had an area of mid-myocardial fibrosis showing up as delayed enhancement on MRI. Untreated, we can observe increased mass, the enlargement of the area of LGE, and the calculated ECV could be higher. However, post-valve replacement, here's another patient who underwent AVR, and subsequent MR imaging shows a reduction in the LV mass, suggestive of reverse remodeling, as well as a reduction in the calculated ECV, although the LGE that represents irreversible replacement fibrosis may not change. Another aspect to talk about is paravalvular leak. Paravalvular leak is more common when we're talking about mitral prostheses, more so in mechanical valves versus prosthetic valves. There are certain locations that are more common, such as along the posterior aspect of the sewing ring. And this can be related to suture dehiscence or infection or due to degenerative causes. PVL can cause significant symptoms such as heart failure and hemolysis, and there are certain also patient factors that pose a risk for the development of PVL. A particular subtype is to talk about is with transcatheter valves and in TAVR valves. What is the incidence and significance of PVL? Well, it obviously is more common in TAVR versus SAVR valves, and more so in the self-expanding prosthesis. Patients with moderate or more PVL have a greater mortality. And so it's important to identify it as well as to predict it based on certain risk factors, such as relative undersizing of the valve and surrounding annular calcification, particularly in the upper LVOT. But transcatheter valves have been evolving such that the sealing skirt has reduced the rates of significant PVL. But this is something that we identify by echo pretty readily. So here's from another ASE document on how do we assess valvular regurgitation following transcatheter interventions. So here we can describe TAVR PVL based on its location on a clock face in the short axis view. And we can quantify the severity based on the circumferential extent of the regurgitation on color Doppler. One thing to recognize is that depending on the way in which you image through transthoracic or transesophageal imaging, you can get a significant attenuation that can mask paravalvular leaks posteriorly on TTE and anteriorly on TE. So it's important to incorporate not only multiple views on 2D transthoracic echo, but also to correlate TTE with TE imaging. And not to go through this, but we quantify it in similar fashion as quantifying native valve aortic regurgitation, with the exception of looking at circumferential extent, where if 30% of the circumference is involved, that is considered significant severe PVL. So PVL closure so PVLs can be closed percutaneously, and there is a Class 2A indication for it if there is significant PVL in NYHA 3 to 4 symptoms in patient who is at high surgical risk and at an experienced center at doing these procedures. As mentioned, the vast majority of PVLs are occurring in the mitral position, so that's where most of these closures are happening. Technical success rate is pretty high, but again, this is dependent on the screening of the patients that are referred for this, as well as the experience of the operator in the center. And the outcomes are importantly dependent on the amount of residual regurgitation, especially if we're talking about hemolysis. You really want to ensure that there is no residual leak or very minimal. And these are a variety of devices that are used off-label for PVL closure and its appearance on 3D TEE. So let's go through some case examples just to illustrate these points. So this is an 81-year-old gentleman who underwent a TAVR a couple years ago, presenting with transfusion-dependent hemolytic anemia. The first step is in assessing prosthetic valve function is always transthoracic echo. And so what was identified was that the patient had elevated gradients, mean gradient of more than 20 with the normal DVI. And also there was this regurgitant jet that was identified on color Doppler with fairly dense continuous wave Doppler signal. And we can localize this jet to on transthoracic echo to the 1 o'clock or 2 o'clock position, which is anterolateral, and you want to confirm it on various views. And typical of paravalvular leaks, it's a very eccentric jet with a jet origin that sometimes can be a little difficult to identify. And so because this gentleman was being considered for percutaneous closure of the PVL, he underwent TEE as well as a CT. So on TEE, you can see that there is a little bit of attenuation, but the jet is in the far field here, but also in the anterolateral position, correlating with the TTE. And we can size it based on the vena contracta width, or on 3D, you could try to size it with the vena contracta area. So what about the CT? So the CT showed that the TAVR valve was well expanded. There was no rocking of the prosthesis. No halt was identified. The leaflets were nice and thin and pliable. And we can see the defect based on looking at a gap in the apposition of the prosthesis to the surrounding native annulus. We sized this defect to about 0.7 centimeters in diameter, similar to what we saw on echo. And it's a little bit easier to appreciate the tract in terms of how serpiginous it is, which this one is not. It's pretty straightforward, and that there aren't fenestrations that may complicate closure. So another example, so this is a self-expanding prosthesis evolute valve, 73-year-old gentleman who was noted to have a significant paravalvular leak pretty early on post-op day 1 from his TAVR. And when we look at this on CT, this is a different mechanism of PVL where you see it's a very underexpanded stent frame with an ovoid appearance here. And there is also surrounding bulky annular calcification in the LVOT that probably contributed to the deployment of this underexpanded valve. And so the treatment for this would be different in the sense that I think this patient underwent balloon dilatation, and I think maybe another valve was placed within to address the paravalvular leak. Now let's talk about just one more case on PVL. So here's a 76-year-old woman who presented with shortness of breath, who had a bioprosthetic mitral valve remotely. And a normal transvalvular gradients, but significant severe regurgitation that was originating paravalvular here, also in the anterolateral position. On TEE, as mentioned, we can use 3D techniques in order to size the defect if you have sufficient resolution, both spatial and temporal resolution, for sizing this defect, which was 0.7 by 0.6 centimeters. Again, due to procedural planning, we obtained a CT on this patient, and you can see the gap here correlating to that paravalvular leak in that anterolateral position. And this is a short axis view. There's also pretty significant pannus here, but this gap is what was mediating the paravalvular leak. With CT, we can also get a sense of what the lateral projection would be to facilitate crossing the defect. So then this underwent a percutaneous PVL closure, and we did use echofluoral fusion for this particular case, where you can overlay transesophageal echo landmarks onto your fluoroscopy and mark certain sites, such as the site of ideal transeptal puncture and the area where the leak is originating. Mark it on echo. You can project it on fluoroscopy to facilitate the procedure, but largely the procedure is guided by TE, both 2D and 3D, for crossing the defect and closing the defect with this occluder device that you see here. Let's move on to talk about endocarditis. What imaging techniques do we use to identify endocarditis and prosthetic valves? Largely 3 modalities are important here. TE is oftentimes first line. CT can be helpful at looking at surrounding structures and identifying paravalvular abscess or pseudoaneurysm. And then FDG PET has lower spatial resolution, but we can look at metabolic activity if there is a question of whether or not thickening truly represents potential infection. And of course, all this has to be incorporated into the clinical context as well. So a few case examples here of prosthetic valves with endocarditis, particularly TAVR valves. Here is a 26 sapien at 6 months follow-up, where on TE imaging, you could see a large echo density representing the vegetation, and of course also seen on CT as well as PET. But sometimes it's not so clear. Sometimes the CT is helpful in seeing things that are difficult to appreciate by echo. So this is another patient with a smaller vegetation, although echo will have higher temporal resolution, so we can assess for independently mobile masses a little bit more readily. Here is the CT of that patient showing the hypoattenuation and the extent of the infection of the infected valve. Root abscess. So here's an example of a patient with a prosthetic aortic valve and paravalvular abscess, which shows up as thickening. That can be nonspecific. But on PET imaging, we see FDG avidity in that area, which would suggest that this is infected abscess. There's also a corresponding vegetation that was seen on TEE as well as CT, which also identified splenic infarct due to embolization. And then pseudoaneurysm is another complication of endocarditis, which can be evaluated by CT. Here's an example of a patient with a mechanical bileaflet mitral prosthesis with paravalvular leak, dehiscence, and formation of a LV basal pseudoaneurysm, and another example there. So with all these potential complications of prosthetic valves, and we're looking at prosthetic valves more, and patients are getting more bioprosthetic valves, we have to talk more about the lifetime management of valve disease, since the life expectancy of patients with prosthetic valves is oftentimes exceeding the durability of their intervention. And Imaging can play a role in planning for the subsequent reintervention, such as valve-in-valve and other percutaneous interventions. So a couple minutes on just CT imaging and how we use it for valve-in-valve planning. So for valve-in-valve TAVR, the first step is in identifying the type of failed valve. We incorporate it with echo and other imaging techniques to evaluate the mechanism of failure. And then for planning purposes, TAVR planning, as we know, is heavily reliant on CT for sizing the anatomy. So in the setting of a pre-existing prosthesis, we can look at the dimensions and whether or not it fits what the known true ID of the prosthesis is, and in selecting the appropriate valve-in-valve prosthesis. And then assessing for potential complications such as coronary obstruction. Oftentimes we do valve simulation on the cardiac CT to simulate a valve-in-valve implant and look at the distance of valve to coronary distance in order to assess the risk of potential coronary obstruction with valve-in-valve TAVR, which is higher than with native TAVR. This all plays into decision-making and multidisciplinary meetings and in selection of potential transcatheter valves, if that's the approach that is felt to be optimal for the patient. When we talk about failed TAVRs and valve-in-valve TAVR, so TAV-in-TAV intervention, there's a couple more anatomic features to consider, such as a neoskirt height, the commissural alignment of the failed TAVR valve, as well as coronary access and potential for coronary obstruction as well. CT has also been shown, and this is an interesting study looking at a device transcatheter heart valve expansion and deformation, and how it might affect valve-in-valve hemodynamics in terms of gradients and EOA. They showed that with the self-expanding TAVR valve, that incomplete expansion of the prosthesis was associated with worse hemodynamics. And this has implications for durability of valve-in-valve interventions. Brief word on valve-in-valve and valve-in-ring TMVR. This is putting in a TAVR valve in the mitral position, since we don't have FDA-approved prosthesis transcatheter valves for the mitral position. Planning for valve-in-valve TMVR also involves CT after you've identified significant dysfunction of the valve based on echocardiography. Importantly, you assess the mitral annulus and the risk for LV outflow tract obstruction. Sizing is also based on this valve-in-valve app and dependent on the size and type of prosthesis that is in place. It's easier than looking at native anatomy in terms of sizing, but what's important here is assessing the risk for outflow tract obstruction. And this is based on something called the neo-LVOT area, which, as you can see in this figure, is defined is constrained by the basal septum and the anteromitral leaflet, or the mitral prosthesis in a valve-in-valve situation, where you have a new LV outflow tract, a little bit more proximal than the native outflow tract. And if this area is small enough, that could cause hemodynamic outflow tract obstruction. And so with CT, we can do is valve simulation by putting in simulating a valve-in-valve implant in the mitral position and planimetering this neo-LVOT. And if it's small enough, it's been shown to correlate with the obstructive gradients. And that threshold is defined at around 170 millimeters squared. There are other anatomic factors that play into neo-LVOT obstruction, such as if you had a patient with a small ventricle, a septal bulge, and a sharp aortomitral angle, and also some procedural factors as well. Moving into kind of the future and things that are in development for assessing for neo-LVOT obstruction. This is a kind of a labor-intensive thing to do manually, and so there are software that are out there to try to do this in a semi-quantitative fashion to look at different phases throughout throughout systole and look at different conditions such as different depths of implants and simulating different valves. And so doing it in a semi-automated fashion has a lot of potential to bring access to doing TMVR and assessing patients for TMVR to sites that are less experienced. So here's an example of a patient with a failed mitral bioprosthesis and simulated TAVR valve TMVR in that position, and you can see the open cells of the prosthesis a little bit better with some of these simulation techniques. And like I said, you can semi-automated calculate the neo-LVOT area, which in this case was a little bit borderline. So in summary, prosthetic valve dysfunction can be due to structural or non-structural causes, and this can lead to progressive stages of hemodynamic change and clinical consequences. Multimodality imaging of prosthetic valves involves the incorporation of complementary techniques to assess different aspects of prosthetic valve function. Echocardiography is always the mainstay in the first line for evaluation of valve hemodynamics non-invasively. CT, though, has an important role in differentiating masses on prosthetic valves that might lead to hemodynamic consequence. And then FDG PET can be used for looking at infection. MRI still has a limited role in the assessment of prosthetic valve function, but that may change over time with 4D flow and other advanced techniques. And so finally, imaging is also key to assessing anatomic suitability of downstream transcatheter procedures for addressing prosthetic valve dysfunction, such as valve-in-valve interventions and PVL closure. So with that, I'd like to close and thank you for your attention. It's also Luke's half birthday today, so.
That was fantastic. Thank you so much, Tiffany. As we are getting our questions together, I'm actually going to pose the first one. It's fairly well established that interventional echo is a subspecialty. Not every place has 3D echo and 3D TE, and there's a lot that is involved with that. But all of these CT images that you're showing look so beautiful. They're just pristine. Is this just a push button thing, except for obviously some of the simulation stuff? But can you basically get these CT images everywhere to look for ham and halt and paravalvular leak?
Yeah, no, of course not. We only show the best that we have. You see in the books, and the guideline documents are always very good examples. But you're right. I mean, like echo and other, CT, of course, has its pitfalls, especially if you have patients who are tachycardic and are in AFib and have breathing artifacts. The other thing is prosthetic valves can have a lot of metallic artifact, and so you have to make sure you have technologists that are experienced in optimizing your parameters for the scan, and doesn't always work. So that's true. And then your question was about interventional echo.
Well, it sounds like interventional echo.
Oh, yeah.
This the CT imaging of prosthetic valves actually is kind of a specialized thing.
Yeah, I think, yeah, the actually how to look at it, and it's this whole, I think it's this whole package of how do we look at valves and know, what could help this patient, what sort of things to look for. If you don't know what sort of things to look for, you may not find certain things such as halt or, small paravalvular leaks. So yeah, you're right. I think it's a lot of using the same lens you use for looking at an echo and applying it to looking at a CT for sure.
Excellent. Any questions from the audience? And have to keep an eye on the chat too.
Okay, nothing on the chat. Okay, all right.
Well, one more question, especially when we're thinking about halt and ham, should we be actually more routinely using CT? And given some of the issues that we have, especially aligning Doppler flows on echo, maybe we're not detecting this when we should be.
Oh, that's a tough one because I also think there's it's not always clear cut when it's mild either. And so you don't want to be treating people for things that may not be of hemodynamic significance. So I still think echo is the first line for trying, and we're pretty good if we get different windows and try to get very well aligned to get to see if there's elevated gradients. But I think you're right. The next step, we should be thinking about CT more when we see abnormally high gradients, because when we do a TEE, we may not be able to see to that level of detail what might be going on. And because the intervention is different than proposing a valve-in-valve TAVR versus anticoagulation, it's important to identify.
A rather large difference indeed with that. Anything from the audience?
Yeah.
Dr. Khan.
Sure. So in terms of the valve-in-valve planning and its application outside of highly specialized academic centers, how much of that is automated within the software and how much of that is very specialized knowledge?
Yeah, that's a very good question. That's being increasingly talked at a lot of meetings, is that, without specialized software, it's very labor intensive, and you have to have like a dedicated imager who's experienced in doing this planning. And so to some extent, that's still largely the case. There's a number of vendors that have dedicated, just TAVR in general, dedicated TAVR packages for looking at cardiac CTs. And that's being, I think, on the vendor side is software, for CT post-processing. That's more and more prevalent. But that's where like some of this like AI stuff with the CT simulation, the hope is to be able to help less experienced centers to plan for more sophisticated transcatheter procedures. But the other aspect is also training and experience, developing that experience. And so I think hopefully there's a new, some guidelines on imaging training, and so how do we train people to be able to look at CT for valve-in-valve planning? That'll be part of that as well. Okay, let me pull it up. I saw it. So Dr. Roth, do CT or MR have a role in a change, roll in or change our approach to prosthesis, so PPM, patient prosthesis mismatch, or prosthesis patient mismatch? Absolutely. I mean, I think with particularly CT, MR doesn't have much of a role in looking at, I think, transvalvular gradients, because we're often underestimating, and it's, the spatial resolution isn't good enough. But I think we're often considering stenosis versus PPM, and in trying to distinguish between the two. That's where I do think CT has an important role, because if you see normal leaflet structure and mobility, then you're favoring PPM as the etiology rather than prosthetic valve dysfunction from the variety of structural and non-structural causes. Yeah, absolutely. I think another thing I didn't get a chance to talk about is that I think on the surgical side, there's, I think, more interest in getting CT imaging, even for surgical planning, to look at the size of the aortic annulus and planning for upfront, things that need to be done, enlargement, and it might play into that kind of heart team discussion on do we consider TAVR versus SAVR. So yeah, I think those are some of the potential roles for CT.
Excellent. You mentioned FTG PETs.
Mhm.
It's kind of hard to get PETs these days.
I wish
Kind of
Lori was
backed
still
up.
here.
Yeah.
Yeah.
What sort of role do you think the nuclear imaging is going to
Yeah.
be playing in the future in valves? And is it just going to be that endocarditis and paravalvular?
Yeah, this is an area I'm not too, I don't practice nuclear, so it's a little bit hard, but I know there are new radio tracers out there trying to identify, I think there's a sodium fluoride one, trying to identify fibrosis, and that may have a role in prognosticating patients who've undergone, valve replacement. Remains to be seen whether there's other applications besides the detection of endocarditis for nuclear imaging. But it's interesting because with various radio tracers, they can look at metabolic activity, and that I think we still don't understand very much the interaction between the prosthetic valve and the native annulus, and sort of what is a normal time course of alterations in metabolism and such. So yeah.
You were very convincing in showing that you need a multimodality and specialized approach to detect dysfunction and all the bad things that can happen with prosthetic valves.
But what about the good things?
Well, specifically timing of intervention.
Yeah.
So you mentioned symptoms. That's obviously a huge issue, and whether it's, replacing something or intervening on it, but really the upfront idea. And we do rely a lot on our assessments of cardiac size and function to figure out when it is that we need to do something before the horse is out of the barn. Do you think that MRI or other techniques need to be employed more in order to help us on that decision making when to intervene?
Oh yeah, yeah, definitely. I think that's another exciting area. I mean, for all the fellows, there's all these exciting areas of potential investigation, right? So looking at the myocardial effects of valvular disease. I think there's a couple papers out now looking at clinical outcomes stratified according to LGE on CMR or ventricular size on chronic AR or chronic MR. So I think we're still trying to understand what the significance of some of these more advanced parameters are. For instance, T1, ECV. What does that mean for progression of valve disease? I think that remains to be seen. But I showed some examples of how with just grossly MR, you can get pretty reliable chamber size as well as LV mass quantification, and that those have already been demonstrated to play a role in timing of intervention. For instance, AR and LV size. So yeah.
It strikes me that we probably need more of that, because right now it just seems so easy to slam these things in, right? And all percutaneous, and it's low risk and all this kind of stuff. But the problem is we're doing older and older folks.
That's right. Yeah.
Who have multi-cardiac mobility. Let's just set aside the whole other multi-morbidity stuff they've got. And so how do we and then we have many more choices.
Yeah.
So how do we actually use imaging to help us make some of these decisions?
Yeah.
And people who, on the other end of it, they may not feel any better. And we probably could have figured that out. Yeah.
So that's why I think some of the exciting studies now, like the one looking at, TAVR, valve TAVR and the deformation, is trying to understand how the structural changes affect hemodynamics and clinical outcomes, and then using that information to feed back to how do we screen patients for intervention in the first place, right? So I think we have to, a lot of these things are still relatively new in the percutaneous and transcatheter world. And so we can use imaging to understand what it is that we're doing and how it's, how these interventions are actually, affecting ideally clinical outcomes, but if not, some imaging, markers, and then using that information to hopefully screen patients better.
Yeah, and let me ask you too about actually, let's go to Larry.
Yeah, just a quick comment and a bit of a question, I guess. This brings up the low flow, low gradient AS patients.
Yeah.
I mean, I'm not sure what that literature looks like.
Yeah.
And cardiac MR, but it seems like a very ripe area rather than just throwing a valve in and the patient either gets better or they don't. I think it would be a great. No,
I mean, I didn't have a chance to talk about that, but yeah, low flow, low gradient. There's studies looking at, obviously, so we can look at stress imaging to try to augment flow. That doesn't always work, and it doesn't always make sense in patients who have the D4 class of low flow, low gradient, but preserved EF. And so then there's aortic valve calcium scoring. And that correlates with the severity of AS and can play a role in the timing of intervention. But you're right, there's probably alterations on the myocardial level that could be potentially identified with advanced imaging techniques in order to help us better select patients for intervention. Yeah, so I think that's where MR could probably be really useful.
Do you think we have a role also in younger patients in the SAVR versus TAVR debate and the idea of bio valve and then TAVR until we have no more room? How do you think we might be able to help that?
Yeah, I mean, I think if we're talking about valve, like, we have to be able to understand what does valve actually do long term. And some of it is there's just not that much data out there. But understanding some of these concepts like related to PPM, we can sort of get a rough assessment of what would happen if you put a small valve in a small valve, and so I think there's increased recognition on particularly the consequences of PPM, and so that plays a role in sort of planning. It's still very difficult, and I think kind of a very multidisciplinary thing and patient-centered approach of how do you counsel patients, especially young patients who are maybe have congenital heart disease, and you're looking at multiple interventions, but what's the right sequence and step? It's hard, but yeah, hopefully imaging has some role in that prediction.
I would certainly think so. Maybe one last question, but feel free to expound on this in the remaining 3 minutes.
Okay. Sorry, I left a lot of time for questions.
No, that's excellent. No, that's absolutely fantastic.
Oh, there are. I don't see them. Q&A. Okay. Let's see.
That's different.
Oh, okay. Ms. Thompson, nice talk. Is multimodality imaging a new cardiac specialty? Should the societies be merged? I love that question. So, yeah, I wish. I think there is a need for it. I think, traditionally imaging is siloed into the modalities. We have our nuclear society, we have our echo society, but there is an upcoming ACC document with multi-societal input on how do we train fellows and other trainees in cardiac imaging. So it's not yet ACGME accredited, but I hope that that's going to be the case in the near future, where it's there's a greater need for imagers and in multiple things, including for valve disease, but and hopefully that'll drive the need for training people that are experienced. All right, and then Kavita, as a cardiologist who does both TEE and reads MRIs, do you ever see discordance in valve regurgitation quantification between modalities, specifically in native bicuspid AR? How do you reconcile limitations of one modality versus the other? That's another excellent question. So I think first step is an understanding of pitfalls. We look at textbook examples, it's always clear cut, but there are always going to be potential pitfalls from a technical standpoint. I think with TE, we understand that your Doppler alignment is very important. And so that's a pitfall of TE assessment of AR. Another pitfall is we can't quite see the ventricle as well. We have 3D echo, but you know, we try to get close to MRI, but MRI is a little bit better for chamber quantification. But on the other side with MRI, flow quantification also has its limitations. If you have you have mixed AS and AR, the velocity, the aliasing and stuff will require you to adjust the phase contrast VENC to be a higher level, so you don't quite get as good resolution for volumetric quantification. And then when we're talking about, you know, the question was on aortic regurgitation, but for mitral regurgitation, it's an indirect method in which we quantitate the regurgitation volume on MRI, right? So it's dependent on how do we planimeter the left ventricle. If you have a prosthesis, then your basal slices are going to be hard to planimeter, and so your ventricular volumes are going to be inaccurate. Of course, if you have a device, and we can do MRIs on patients with ICDs, but as Andrew knows very well, that it doesn't work very well sometimes if you can't see if there's a large artifact.
So you're really highlighting the fact that this is a specialty, that all of the pretty pictures you're showing, a lot went into that, and a lot goes into understanding the pitfalls and the things that you have to integrate across all of them.
Yeah.
So then what made you want to be a multimodality cardiologist?
Yeah, well, I think if you're really passionate about imaging, you start exploring, well, what about these other modalities? What can I do with CT? And especially, I think you have to start out with a focus of what your clinical interests, or what disease, whatever it is that you're interested in, and then think about how imaging can help you get there. And that increasingly is requiring more than just one single imaging modality. Yeah, to be interested in imaging, I think it takes patience. It takes a lot of, I think a lot of, you have to be really interested in looking at things and understanding how it can change. How is it going to change, patient outcomes? Not just making pretty pictures, but why is this important? And so I think the whole process from, if we're talking about being an interventional imager, it's the whole package where you understand what kind of interventions are out there, how they're done, how they affect patient outcomes, and how do we screen for patients, what I can use for my imaging toolbox.
Would you say your imaging makes you a better clinical cardiologist too?
I hope so, because then, I think everybody should understand what, even if you're not reading these images, what you can use these diagnostic tools for. And yeah, I hope so. Yeah.
Well, that's fabulous. Thank you all for joining us, but a big thanks particularly to Tiffany. That was phenomenal. You have contributed so much to our fellowship and our imaging program and our division of cardiology, and a huge happy birthday to Luke today.
All right. Thank you. Thanks.